Before we jump into the episode, I want to thank our newest How I Doctor sponsor, Sevaro. Sevaro is a top telestroke and neurology company that was built to fix one of the most predictable failures in modern medicine, getting timely, consistent access to a neurologist when you actually need one. Their team of board-certified neurologists deliver rapid video response, clear decision-making support, and continuity from the first exam all the way through treatment planning and management. Hospitals working with Sevaro see faster door-to-needle times, fewer transfers, and measurable improvements in patient outcomes. And because Sevaro was built by physicians, the workflows actually match real-world medicine. If you need stronger, faster, and more predictable neurology coverage, visit Sevaro.com to learn more. And now, let's get into today's episode. Before we jump into the episode, I want to thank our sponsor, Evidently. Evidently is the clinical data intelligence platform built to help physicians harness the ocean of patient data they're drowning in every day. From chart summarization to AI-assisted note drafting and denial appeal support, Evidently makes sure the right data shows up at the right time. Physicians using Evidently report spending less time hunting through charts and more time focusing on patient care. That's why they've become a trusted partner to health systems looking to improve documentation, quality, and revenue sustainability. The company is led by providers and AI researchers that are dedicated to reducing documentation burden and helping clinicians practice at the top of their license. If you want to see what Evidently can do for your hospital or your practice, reach out today at www.evidently.com. Now, let's get into today's episode.
Saturday night, 10 o'clock, I get a call from the CMO of a hospital. He's like, hey, we have a stroke patient. We've been trying to get in touch with you. So my phone never rang. I had no idea. Saw the patient, examined him, thrombolytics, but that patient had delay in care. I said, this is happening all over the country. And how do we eliminate a rate limiting step that caused a 20-minute delay from the patient care? And we need to make it simple. You call a number, you get a doctor. That's it. 24/7, 365. I don't want anyone in between.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, we're talking about one of the most urgent and most invisible crises in American healthcare. What happens when a stroke patient lands in a rural ED at 2 a.m. and the nearest neurologist is 100 miles away? For too long, geography has been the single biggest predictor of whether the patient walks out of the hospital or doesn't. My first guest, Dr. Raj Narula, is a board-certified vascular neurologist who faced what he calls the toughest decision of his career: pursue neurointerventional radiology fellowship or go build something that could reach thousands of patients instead of one at a time. He bootstrapped Sevaro Health and has since raised investment to build an AI-enabled virtual neurology company that now serves over 150 hospitals with a promise that I think sounds legit impossible: get a board-certified neurologist on screen in 45 seconds. Joining him is Dr. Melanie Winningham, a vascular neurologist who brings a genuinely unique dual perspective, I think, to the conversation. She's the medical director of a comprehensive stroke center in Virginia. She chaired the Virginia Stroke Systems Task Force, and she's also VP of Clinical Strategy and Partnerships for Sevaro. So she spent side on the neurology access gap with hospitals, and now she's trying to close it with Sevaro. We're going to talk today about what telestroke actually looks like on the ground, whether it's keeping patients local and giving them better outcomes, how AI is changing acute neurology in real time, and what it takes for a physician to build a company from scratch in a space dominated by much bigger players. Doctors Narula, Winningham, thank you so much. Welcome to How I Doctor.
Graham, thanks for having us. It's a pleasure.
Thank you for having us.
Raj, you've said that the date April 24th, 2017 was the big day. Neurointerventional radiology fellowship on one side. It's lucrative, it's prestigious. You're in there and like doing clot retrieval and clot busting. And then there's like building a company on the other side. I talk to physicians all the time who are maybe like you in 2017. They have these like dual tensions. What made you pick one over the other?
I'd always wondered, well, will I regret this looking back or not? Choosing one path of, amazing, competitive, life-saving work, really changing the shape of someone's life, you can through a neurointervention, or trying something that was a lot riskier. I was at University of California, San Diego at this time, moving on to my next phase, and I realized the practice was evolving. And the way we practice neurology was not how we were going to practice it in the future. But I realized that the field of teleneurology wasn't given what I felt the right attention that it deserved. And I didn't really see anyone really focused on the patient care side of it and the quality. And then the other side, who was focusing on the neurologist providing the care. And, back then it was just get a doctor on the screen and that was the bar. And I said, if we don't fix this as neurologists or as physicians, who's going to do it? So I had to make a tough decision. And I made a bet that if we built the right technology, the right infrastructure to help physicians practice better, we would not just be helping one patient, but if this worked, we could help thousands, maybe millions. And along that way, our neurologists would feel more comfortable in the way they practiced.
It was 2017 when the big large vessel occlusion trial came out that really said, hey, if you have a large vessel occlusion, like which usually presents as a very significant deficit stroke, you do better with clot retrieval.
Melanie?
I want to say it was Nashville. Was that the year? Sounds right.
Yeah. So there were trials prior to that, which really were concerning in terms of not showing that there was.
That's right. Yes, I remember this. Yes.
And this was a time now where the proof was there, the evidence was there, even up to 24 hours showing that there's a benefit. So this was a field that was booming, budding. The field of neurology has evolved so much in the last 5 to 10 years. And that's why we're so excited about it, right? It's just going to continue now that we have technology to enable us to provide better care too.
I think of that paper as a prime example of how the standard of care can kind of change overnight. The day the paper comes out, you start to see, the entire field of stroke care needs to fundamentally change workflow as soon as possible because this massive trial is now saying, whoa, the way we've been doing things fundamentally is different than it was yesterday, which is kind of crazy to think about.
And the guidelines also have been evolving and changing. Recently, we were at the International Stroke Conference just a few weeks ago, and the new American Heart Association guidelines were just released showing that there actually might be benefit to extending the thrombolytic time window out further as well. And that is an opportunity for us to do what we are worried about. There are not enough patients being treated for stroke yet. And we want to be as inclusive as possible to treat these patients. So the research, these types of studies that, like you said, practice-changing studies and guidelines are exciting.
I would imagine neurology is like many specialties and fields where the burden of disease is just fundamentally way larger than the number of humans capable of managing them. Is that your experience, Melanie?
Yeah, I think I saw something somewhere that said over the past decade, we've had a net increase in neurologists. It's 600 over a decade in terms of our workforce.
Wow.
But with an aging patient population, right?
Yeah.
All of these diseases that are age dependent, we have more patients and fewer practicing neurologists. So we have to find a way to meet that need. We have to be creative.
Yeah, I've looked back at like some of the old legislation. Clearly, like the number of residents and the number of residency slots for whether it's emergency medicine or neurology has not kept up with population growth at all. And then, like your point is perfect, Melanie, that just with the aging population, there's going to be more strokes and there's going to be more problems that require specialty care.
One is our population's aging and having more complex neurological disorders as well. The other side of it, we just have studies that have been published recently showing strokes are getting younger and younger. And in a younger population as well, we're now seeing it. So Melanie, myself, and our colleagues, and you probably see this in the ER as well, there are 40-year-old patients coming in with strokes, unfortunately, now as well. So this type of a dilemma is what we're dealing with on both sides of it.
Is that thought to be just from metabolic disorders and dysfunction of younger and younger people in terms of living with, if they've had type 2 diabetes for 20 plus years, they're going to have significant atherosclerosis and significant neurovascular disease?
So I think that definitely plays a big role in it as well. our own lifestyles here in the United States are very different. The types of food we even eat here are very different. Our exposure to different things in our environments are very different as well. And then the genetic causes, of course, but it's concerning. We are on the receiving end of seeing these patients.
Walk me through what Sevaro does differently. Not the pitch. What's the actual mechanism? What's the doctor version of what's different?
We have a cool system that it uses what's called one call, which basically every hospital partner that we have has a unique phone number, right? And so that number is dialed by the ER doc, which connects you to one of our stroke experts immediately, taking the call center out of the equation. It's not paging, it's not waiting for a call back. So you're going to talk to us and you're going to say, "Hey, I have a patient with right-sided weakness. This is the time of onset. This is what I know." And that starts that encounter right away with no middleman. And so it generates for us in our system an encounter for our patient. We have AI tools that help to document as we have that conversation, to create the note, to create a pathway for that patient, to create workflow and decision-making support for our physician. So all of that is happening simultaneously, which is why folks love to use the technology, the clients and the physicians, right, on our team.
What would you guys say was the experience prior to telestroke availability? What was the version of your guys' experience before this was even feasible or possible?
Yeah, I'll give you an example, Graham.
Yeah.
Saturday night, 10 o'clock, I get a call from the CMO of a hospital. He's like, "Hey, we have a stroke patient. We've been trying to get in touch with you." So my phone never rang. I had no idea. Saw the patient, examined him, thrombolytics. But that patient had delay in care. We looked at what happened. That own hospital's call center never answered the call for 20 minutes. I said, this is happening all over the country. And how do we eliminate a rate limiting step that caused a 20-minute delay from the patient care? And we need to make it simple. You call a number, you get a doctor. That's it. 24/7, 365. I don't want anyone in between taking any information except the ER doc and the neurologist, or a nurse and a neurologist. Simplicity in healthcare is often missing. We're trying to overcomplicate things. And I think when you have technology made by non-clinicians or non-physicians, I feel like we tend to see that.
I want to take a moment to thank our sponsor, Sevaro. If you've ever waited and waited for a neurologist to call you back, you know the problem that Sevaro was built to fix. Sevaro is a physician-led telestroke and neurology company that delivers rapid virtual neurology coverage that's reliable. Their board-certified neurologists connect by video in under 45 seconds, and they stay with you through the entire decision-making journey. Hospitals working with Sevaro report faster door-to-needle times, fewer unnecessary transfers, and measurable improvements in patient outcomes. If your hospital needs stronger, faster, more consistent neurology coverage, visit Sevaro.com to learn more. A quick word about today's sponsor, Evidently. Their platform turns an ocean of fragmented clinical data into concise, actionable insights, chart summaries, note drafting, denial appeal support, HCC capture, so you spend time caring, not chasing. A transplant surgeon at a large academic medical center recently took transplant referral review from 2 hours to 20 minutes with AI-assisted chart review from Evidently. Physicians deserve workflows that improve accuracy, reduce exhausting chart biopsy, and help us practice at the top of our license. If you want to see how this might work in your hospital or your department, go to evidently.com. That's evidently.com to get started today. You're reminding me of what my good friend of the podcast, Mark Cuban, says. I mean, Mark literally is like, just get the doctor and the patient together. Everything else is extraneous and clutter and middleman and bureaucracy. Like, fundamentally, if you can just connect the two pieces, you can deliver better care because you're getting rid of all the other stuff in between the two people that need to communicate with each other. The other thing, as the ER doctor on the sending of the consult end, that I think has actually made neurology and emergency medicine closer than before, is just the neurologist's appreciation for the chaos of emergency medicine. There's just often so much chaos that sometimes I'll see my neurologist on the screen with my helping with a stroke alert. And I just get a little, I just like kind of smirk because they have an appreciation for all of the chaos that we're trying to calm and settle such that we together, me and the neurologist, can figure out, is this a stroke? If it is, what's the time of onset? Like gather those critical pieces of information. I think actually the video portion of both of the specialists and the experts trying to work together on this, I think has actually brought the two specialties together too.
I believe that.
I remember getting a call 2 a.m. from one of my ER doc friends in Jeff City, Missouri. He was like, "Hey, Rod, I just wanted to run this case by you." I was like, "Okay, no problem." Runs the case by me, something non-urgent, hangs up. And over time, even though we're virtual, you end up building this rapport with the ER docs, and they know your quirk, you gotta know their quirks after a time, but we've never met in
Oh,
person.
totally.
And,
Yeah.
and I always realized and felt that the virtual environment already has this inherent barrier. We have to be a little bit more intentional about building that rapport. And Melanie is actually the perfect example. I've heard this from a few other people of like, "Hey, I worked with Melanie and I called her when I needed advice on my mother's neurological issue." I've never met in person.
I love that. I love that. Melanie, you've directed a comprehensive stroke center. You've chaired Virginia's stroke task force. You've done NIH research at Emory. I want to get a sense of what the neurology access gap looks like in a place like Lynchburg, Virginia. What does that mean in terms of patients accessing care or the gaps or the challenges or the things you wish could be different about the system?
I think for places like Lynchburg, there may not be another academic center or thrombectomy capable center for an hour, hour and a half, right? Long, long drive. And so when you don't have those resources for stroke expertise, for thrombolytic, definitive thrombolytic therapy or endovascular services, it's a desert. And these patients, we're in the middle of the stroke belt there, right? So these patients have a lot of comorbidities. They have severe stroke syndromes. They're more likely to have LVOs. I see a lot more LVOs that are not lytic candidates than the other way around, right? Just because patients tend to wait to come in. And I think it's important when we talk about rural health that we get it right with virtual care, that we empower our ED docs, that we're calling back, we're seeing these patients quickly, we're keeping patients in their community because that creates confidence for those patients and their families and their community so they're more likely to come in earlier. They have a good experience, they share that experience. And so it's this multi-step process that creates better outcomes over time because we're filling those gaps, we're doing it creatively, and we're keeping patients in their communities. And so in places like that, right, where the resources are scant, the way that we implement virtual care is so important that we're getting it right.
I almost wonder if in areas with less access to quaternary care or comprehensive stroke care, does having access to a teleneurologist or a stroke expert allow that own hospital to upskill and provide, whatever it is, 10, 20% more comprehensive care than what they would currently be able to do because they have access to a neurologist that they maybe would normally have access to on demand?
Well, they keep their patients, right? When you have access to stroke expertise, that neurologist may also be managing the seizure that was the stroke
Yeah.
mimic or whatever that is. You've got somebody that allows you to keep that patient in your hospital and follow them along, often with continuity. So it's not just the acute stroke management, but it's the neurohospitalist services or the rehab consults or the virtual outpatient care. Like nowadays, we can take that patient all the way through the patient care journey so that they do have access to those resources. And I would say that we manage 95% of diagnoses just as well virtually.
Yeah.
Obviously, we can't provide endovascular services through video, but if a lot of patients are getting lytics or they're getting other medical managements that don't require a transfer.
Do you guys think that the setting of care kind of mandates that patients have different management? Does the geography change how patients are managed based on the fact that the transfer time may be long?
We know it's important to figure out what what treatment needs to come first? What's the definitive treatment? If it takes me 2 hours to get somebody to a comprehensive stroke center, it may well put them beyond their treatment window for thrombolytics, right? So I think we talk a lot about this, about bypass at the state level. I think most folks would agree if it's 2 hours to get to a comprehensive stroke center, go to the closest place where they can get thrombolytic therapy and stabilize the patient, get imaging, make sure it's not a hemorrhage, those kinds of things, right? The time to treatment is really the number one determinant of a good outcome. So if you can get that patient a thrombolytic drug within 60 minutes at a community hospital, at the end of the day, we're probably more likely, if they don't have an LVO, to walk out of the hospital and spend the rest of their life in a nursing home. That 2 hours from now, that stroke's a done deal. That's what we have to keep in mind is what is the definitive treatment? What do those transfer times look like? And what's the best thing to stabilize the patient early?
And I often find as a transfer outer of patients, the transfer time that doctors tend to talk about is the driving time. But then if you add in all the other buffers and delays that come with, oh, okay, EMS is here, but now EMS has to get report. Oh, now they have to fill out paperwork. Like all the other stuff adds additional time. I'm like, oh, it's a 30-minute drive across the bridge. Well, how did it take, another hour and a half for this person to get to the operating room? Because there's just other times that we don't really think about when we call something a 2-hour transfer time too.
There's the waiting on the callback. There's
Yes, exactly.
who's the accepting. There's the layers.
Who's opening the OR?
Yep.
Yeah. Raj, I want to pivot and talk a little bit about the AI portion of Sevaro that you've shown me. You really built it physician first, trying to understand how you could leverage AI to help a neurologist do neurology work, which I think is really cool. Walk me through what the AI is actually doing with Sevaro during a stroke code. What tasks is it performing?
Yeah. When we thought about practicing, we realized the technology we needed to practice didn't exist. It was more suitable for primary care. We are operating in an environment that's very fragmented. EMRs don't talk to each other. We need video platforms, imaging access. The data is very siloed. And if we didn't create it, we didn't know how it would happen. So we kind of had to do this by force and by necessity. So we built it ourselves and physician built for physicians by physicians and anchored it around what does the neurologist need and what does it solve for? So we're solving for communication, right? Immediate access, no call center in between. Real-time data and analytics as well. The documentation for AI is layered right in there as well. The revenue cycle management part is built into this as well. And now the scheduling side is also built in. So now you think about this, it's not just a platform, it's actually the infrastructure for what a hospital needs and what a neurologist needs to practice. So the way we've architectured this is let's make it as simple as possible for a hospital to get a doctor. Everything else in the back end, the infrastructure, don't worry about it.
Yeah, we'll just take care of that. Yeah.
The data is automatically collecting. So that phone call that you make to me, Graham, when you're in the ER and I see your patient, and that 45-second blurb of left-sided weakness, right-sided gaze preference, 75-year-old male, I just hang up and half of my note is already done. Right now, that whole pathway of my note and all that continues. I can be on my cell phone and do all of that. I can be on the computer. So we've enabled it in a way for how we really practice medicine, inserted the AI into areas that we think made sense, not vice versa.
It works, I think, because you guys are able to drill down to the fundamental things you need to manage X problem. I mean, I know we're talking a lot about stroke, but I think you guys do other stuff too. But like, just take stroke. There's a checklist of things that everybody needs to gather every time.
What we wanted this to do was anticipate what does a neurologist need to do next or think about next and turn this into a clinical decision support platform. We want to be very conscious and careful of ever allowing AI to make a clinical decision, but allowing that to support better decision-making for the practicing physician is where I think is important for it to stay. I think if we go a little further than that, we're risking a lot, and I don't think that's our intention at all.
Is the idea that the AI can help bubble up what the next steps that the neurologist might want to take are? That it's okay. I've gotten to this point in my differential or my workflow or whatever, and then the AI is helping the neurologist to see, oh, these are the three potential options.
Yes, things like that. And then how do you then layer evidence-based practice into a platform? How do you then think about clinical trial enrollment for patients that meet a certain criteria as
Mm,
well? How do you qualify if a patient that's an Alzheimer's patient may need a certain medication or not?
sure. I want to get back to something you said. The tasks that a neurologist does are different than a cardiologist or different than a pediatrician or an ER doctor. And building the tool of your dreams to help you get through your day, I think is a fundamentally really important part of um, technology enabled doctoring or technology enabled medical care.
Absolutely. And it's not done, right? So the beautiful thing about this technology is you have 100 neurologists using it every day. And we have an entire team of folks who are developing and improving and building. And when you have that interface between your tech team and your developers and your clinicians who are using the tools, you're always going to get the best version of a solution in real time. That's the really special thing about Synapse.
And that's really the philosophy around the whole patient journey. From acute care, we should be able to follow that patient when they're admitted to the hospital, whether it's ICU or on the med surge floor, uh, and then outpatient, and then rehab. And all that data should go back to one place. And we should be able to visualize one patient's journey through the health system of they came in, they were treated, they recovered. 2 weeks later in clinic after they left the hospital, they're back to normal.
I love that vision of, I think as healthcare has gotten more fragmented, there's more shift work, there's more handoffs. That level of clinical knowledge transfer is worth its weight in gold.
Yeah, Graham, that reminds me of med school. You're like presenting a patient to your attending, like this is exactly what they look like, exactly what happened. You walk in the room, completely different story,
Oh,
right?
totally. Yeah. The attending
And
effect is real. Yeah, for
yeah,
sure.
yeah. No, so that's exactly how it works, right? I should be able to do everything that I would do in person with a patient in the same way and do that virtually. How do we mimic that? So that's also the inpatient side of it. Of after a patient's admitted to the hospital, we should be able to round on them, right? Examine them, show them their image of the brain on the screen, right? Of where the stroke was as well. Talk to the family, comfort them in one of the scariest moments of their life as well, and still make sure the in-house team, the hospitalists, the ICU docs, the cardiologists are aware of what is the plan, what's going to happen, and they should feel confident on the other side. I have an academic trained neurologist, even though I can't shake hands with them, but I've shared a commonality of taking care of a very sick patient together, and that trust starts to build over time too.
Yeah. I wonder, you guys, if just the concept of teleneurology has changed who is interested or goes into the field to some degree. Neurologists can be shift workers was not something that I would have said during med school. A neurologist was a very different thing. Are you guys seeing that in newer grads or younger grads, a different mentality or a different interest based on the fact that they can do teleneurology work?
I would say so. I think there at one point in time was maybe a lot of stigma around teleneurology is what you do if you're not in academics, or
Oh,
it's what you
interesting.
do it's what you do as an extra gig. And I even had some of my own personal beliefs a few years ago before I was introduced to Raj and to Sevaro. And I think what we're seeing is that we're able to practice high acuity, meaningful neurology, it's tech enabled, and really have everything we love about stroke care, and to do it in a way that reduces cognitive load, right? And administrative tasks, which is what leads to burnout, which leads to stress in folks. And so I think it's a nice way to get these bites and increments of acute care being well supported. And I think that's reimagining a career in virtual care. I don't think 20 years ago or 15 years ago, people were like, I'm going to be a virtual specialist.
No,
It was
never.
not a thing.
It was not a thing. Yeah.
Right. And so I think that's making it possible for us to build careers and support care in a way that we might not have imagined before.
But I think that we also tend to choose our job and hospital and health system based off their EMR. What platform and technology are you using?
Sure.
And
Yeah.
everyone's got their favorites, and that might impact where you work or the retention of that hospital for their own physicians. I'm pretty convinced that neurologists will choose their future jobs of what platform a hospital is using for virtual neurology because it is becoming the standard of care and a normal expectation. If you're a neurologist, you're likely going to be doing something virtually, whether it's within your own hospital system, outside to spoke hospitals, spoke sites, or through a company as well. And I think it's exciting to see that people see this as another option after training as well.
Yeah. Melanie, neurology has a fairly high burnout rate too. Do you find that the virtual model helps with burnout, or does it just kind of redistribute it, do you think?
The things that would support a good work-life balance about virtual care, and particularly as the way I get to practice with Sevaro, is that, we have a balanced workload through technology, right? The way that patients come in, the way that we see patients, and I think that's one thing about tele is I've heard that it's sometimes like drinking out of a fire hydrant, of a fire hose, right? It's like a constant stream of consults, and there's no regulation around that. I think that's Sevaro's done that really well. I think AI-powered documentation, I think that's been helpful. We have a community that I don't feel siloed, right? And I think that may have been different when virtual care was instituted. And in our community, particularly, we have really academic conversations and chat groups and journal sharing. And there's a lot of stuff that I think makes me feel anchored and connected to my colleagues. If those things, the way they were done, particularly at Sevaro, were not there, I'm not sure that it would be the same for me. And I would probably still experience a lot of those burnout symptoms. And I think other folks sometimes in tele may still have that.
I know you guys are very connected to all sorts of technology. I feel like neurology is also one of the most imaging heavy specialties where like neurologists tend to read all their own imaging as well, in my experience, at least like when they're doing stroke stuff too. They'll like listen to the radiologist, but they'll also look at the imaging themselves. Where do you guys think neuroimaging goes with AI?
I think what I'm seeing is, we have several big companies that offer AI-powered imaging sources to analyze imaging, right, and give early reads. And I think that what we're trying to do, or what I see at least, is trying to get more and more information from the simplest modality. So if it's a
Yes,
non-contrast
completely. Yeah.
CT, what can we figure out from a non-contrast CT without giving the contrast or doing perfusion? And I think there's that shift of trying to get answers quicker about what to do for the patient. I think we'll continue to see a bit of a race to see who can get the best tools on the simplest modality. I also think that, there's a lot of back and forth around, is more imaging better? If I had to answer that in one trajectory, is everybody's going to be focused on using AI to get that tool that everybody has access to. Your community hospital, they don't have an injector for their CT, non-con. How do we find an LVO? How do we make sure this patient's a great thrombolytic candidate? All from a CT. I think that's where it's going.
Yeah, I love that. I completely agree, Melanie. I think there is so much more signal in even non-contrast studies, risk scores that I think will give us all a lot better discriminatory ability between this and that. I would love to see, a newer ABCD2 score that maybe uses a non-contrast head CT as part of its risk stratification, right? You take some of the patient's history of present illness, you take some of their risk factors, you take whatever their blood pressure at presentation, whatever we want to do. Maybe they get a non-contrast head CT. A lot of places are doing MRs for all of these patients. But I wonder, I might even bet $1 or 2 that you might actually be able to get pretty good TIA prediction rates from, a score that combines kind of some clinical knowledge with some risk factors with even just some non-contrast PET CT imaging. I don't know. I could be wrong, but I wonder if there's a better way to do so much of what we do in medicine around just risk stratification too.
Absolutely. Sometimes we see the strokes that never had symptoms on the non-con CT, and then you get the extra points on the scale.
I've got a few rapid fire questions in our last few minutes for you guys. You ready?
Let's do it.
Finish this sentence. The biggest mistake a rural hospital can make with telestroke is...
The biggest mistake a rural hospital can make with telestroke is not to work with Sevaro.
Good answer. You're hired.
I think it's, the fact that we eliminate the middleman, you get that immediate connection. That's what matters in the situation where we might have to transfer the patient, you need timely treatment. We're connecting immediately. So I think if you're working with anybody else that doesn't use that process, that's the mistake.
You mentioned rural health, and I thought maybe a nice time to give you a little background on an initiative that we just started. So it's a coalition called the National Specialty Care Access Coalition, led by Dr. Chetan Satya, a public health official.
I'm getting him on my podcast, and I'm going to be on his in like a few weeks.
Amazing. Yeah. Amazing guy. So he and myself started this coalition. We're bringing about 20 to 30 health systems together to really talk about how do we have their voices at the table, speaking from their lens of what they're seeing in rural America and helping shape CMS policy for how and what they really need to help improve care.
I think you literally just read my mind. One regulatory change that would unlock the most growth for virtual neurology. What is it?
One regulatory change that would unlock the most growth for virtual neurology is to eliminate the state licensing requirements across the country.
I think that would fix so many problems, not even just virtual neurology. Maybe just give me your perspective. Why is that so challenging?
Each state has their own requirements before a physician practices in that state. I've got almost 30 state licenses, and they're all asking about the same exact questions. And it's just a form-filling process that we have to go through. We have physicians, we have nurses, we have the ability to touch and care for these patients. And there's a blocker right there.
And so then on your guys' end with Sevaro, if I'm the ER doctor in Kansas asking for the Sevaro neurology consult, Sevaro then has to match with a neurologist who has a license in Kansas. And obviously if we had a American medical license, that problem would go away.
Exactly.
Raj, where can people find out more about you and Sevaro?
Yeah, definitely on our website, sevaro.com, sevaro.com, and find me on LinkedIn. I love that.
Amazing. Doctors Narula, Winningham, thank you so much. It's been really great to talk to you about stroke care and teleneurology. Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.